Here we are at the inaugural event of the International Sleep Charities book meeting. I'm Charlie Alton. I'm one of the co-founders of the charity, and I'm really delighted not only to have our first British speaker, but if we're going to have a first, we might as well have top-notch. And today we really have got top-notch. Professor Russell Foster, CBE, specialism is Circadian Neuroscience. He's director of the Nuffield Sleep Centre and also a Nicholas Kurti Senior Fellow at Brasenose College, Oxford. So he's going to be talking about his book, A Very Short Introduction to Sleep, for 20 minutes. And at the end of which, we're going to have a relaxed and informal discussion, question and answers. And that's how it'll all work. So please, if you've any questions, could you keep them until the end, or if you don't feel like public speaking, you can send your questions in on the chat function, and Dr. Yizu will pick those up with Professor Foster afterwards. So enough from me, and without any further ado, I'm going to hand over to the main event. Professor Foster, thank you very much for joining us, and over to you, sir.
Thank you very much indeed, Charlie. Really a great honor to inaugurate this event. I mean, it's amazing. Can everybody see this all right? Yep. And can you see my pointer?
Yes.
Okay, fantastic. Well, many thanks. What I thought I could do is give a sort of a very short introduction, about 20 minutes, about the book. But I'd also like to refer you to a later publication, which is on circadian rhythms, a very short introduction. And I think of the two, I think this is possibly a better book in that it's probably got a bit more detail. And I was allowed to have a bit more editorial control over this. So I think it's I think take the two books. I thought I'd divide the 20 minutes up into three basic sections. First of all, the biology of sleep and circadian rhythms, some of the issues and some of the problems that occur if you don't get appropriate sleep or suffer circadian rhythm misalignment. And then the third section on solutions. I won't go into any detail. I'll just refer you to the paper I circulated. But of course, we can talk about solutions a lot in the Q&A. So if we kick off with the biology, and really want to make the point, and it's such an obvious point, really. The different states of sleep and consciousness are so profoundly different. It requires a complete and utter realignment of every aspect of the brain. So we see that every key neurotransmitter system is changing across the sleep consciousness cycle. And this is in turn driven by key and multiple structures within the brain. So the hindbrain, the midbrain, and of course the cortex are all interacting to generate these two profoundly different states, part of which during sleep will be the REM, non-REM cycle every 60 to 90 minutes. And we may want to discuss what we know about the non-REM cycle and why it's been important. In fact, what we've learned from the non-REM cycle. But I'd also like to make the point that this extraordinary flip-flop from sleep to consciousness involves two really important timing systems. The first is the biological clock, the circadian system, which is time stamping all of these events. And the biological clock is working with perhaps the most intuitive part about sleep, which is sleep pressure, which basically means the longer you've been awake, the greater the sleep pressure and the greater the need for sleep. And the buildup within the brain of substances like adenosine have been associated with sleep pressure. One more component that is particularly important and an area that we've spent a lot of time studying is the role of the eye in detecting the light-dark cycle, which is then setting the biological clock, the internal day, if you like, to the external day, and essentially then allowing an appropriate alignment of the sleep-wake cycle to the external light-dark cycle. Okay, let's look at that interaction in just a little bit more detail. And first of all, let's look at the sleep pressure. So we see here the wake-sleep cycle. And from the moment we wake in the morning, the sleep pressure is building and building and building. And then whilst we're asleep, the sleep pressure say adenosine is broken down, and the sleep pressure dissipates. Now, what's really important to note that now in the early evening, our sleep pressure will be really high. And the reason we don't fall asleep is because of the action of the biological clock or the circadian system. What's happening is that the circadian system is providing a drive, if you like, for wakefulness. Now, the drive for wakefulness in the morning is very low, and that's because the sleep pressure is very low. But as we go through the day, the wakefulness drive increases and increases. And in fact, it sounds almost counterintuitive, but the wakefulness drive from the clock is at its highest just before we fall asleep. As we slide into sleep, the wakefulness drive diminishes, which then allows us to initiate sleep. And then during sleep, the wakefulness drive is low. And then as we approach wake and morning, the wakefulness drive kicks in, and of course, we wake up. So you see these wonderful two interacting factors. And this figure sort of explains that if you wake up during the first half of the night, it's very easy to get back to sleep because the sleep pressure is still high, but the wakefulness drive is very low. It's more difficult to get back to sleep if you wake up late in the sleep episode because the sleep pressure is diminished and the wakefulness drive is kicking in. It's worth also adding that in our species, there's a third factor, which of course is societal pressures. The alarm clock provides an overwhelming drive, which can disrupt the biological drivers of the circadian system and the sleep pressure. Classically, for night shift workers, these systems are completely disoriented. And of course, if you're drinking lots of substances like caffeine actually blocks the receptors within the brain that detect adenosine. So you genuinely feel more awake after a cup of coffee because the brain can't detect the buildup, the higher levels of adenosine. Okay, let's now look at the biological clock in a little bit more detail before we discuss what sleep provides us. We know now quite a bit about the biological clock. The master clock, if you like, is located within the anterior hypothalamus of the brain, the suprachiasmatic nuclei. This small paired structure, about 50,000 individual cells, represents the site of the clock. And if this area is damaged, then beautiful 24-hour rhythms like the sleep-wake cycle become completely disrupted. Now, the SCN and the circadian system not only timestamp the sleep-wake cycle, but essentially every other aspect of our physiology and our behavior. And just to show you a few examples here, we see 6 boxes, and we see that the time base here is from 2 o'clock in the afternoon to 2 o'clock in the afternoon, so a 24-hour time base, and the gray area represents roughly when we're asleep. And the first hormone we'll look at is melatonin, the pineal hormone, and you see that it rises in anticipation of dark and sleep, peaks, and then declines in anticipation of morning. Now, melatonin is not a sleep hormone. It's a biological marker of the dark, and it's a modulator of sleep. We may want to talk about that in a little bit more detail later. There's a lot of confusion out there that melatonin drives sleep. It absolutely does not. If you're taking beta blockers, you don't have a rhythm of melatonin, and you can sleep perfectly well. You have a relatively normal sleep-wake cycle. So it's a modulator. So we see this for melatonin, and basically any other hormone or behavior you look at shows this 24-hour circadian-driven change. This is growth hormone, very sharp rise during the first half of the sleep phase, where cellular tissue repair is going on. Core body temperature shows a very nice rhythm in circadian change, and it's this drop here in core body temperature that has been associated and important for sleep initiation. Cortisol rises to this peak first thing in the morning, similar change in testosterone, and of course our multiplication accuracy changes across the day with a really poor performance in the early hours of the morning. And the point is that these changes are underpinned by the circadian system. Essentially what the circadian system is doing is fine-tuning physiology and behavior to the varied demands of the rest, the sleep, activity state, which is in turn aligned to the light-dark cycle and the rotation of the Earth on its 24-hour axis. I want to talk about some of the health consequences of a dynamic 24-hour physiology. And again, it's something we may want to unpack a little bit in the question period. This is an example of the frequency of ischemic stroke, and it's data provided by Peter Rothwell, my colleague. Now, what you see is another one of those boxes with a 24-hour time base. In this case, we're going to look at the change in blood pressure. And we see that there's a slow drop in blood pressure, gets to the low point again around about 4 o'clock in the morning. But then in anticipation of activity and the need for greater nutrients to the tissues, greater oxygen to the tissues, the blood pressure rises, and there's this very sharp, endogenously driven rise in blood pressure. And that sharp rise corresponds almost perfectly with the frequency of stroke. So we've got time of day on this axis here, and that we've got the frequency of stroke in a large population of individuals. And the bottom line is that between 6 a.m. and 12 noon, there's about a 50% greater chance of having a stroke than any other time of the day. Now, why is this information useful? I think it's important in two regards. One is when to take your medications. So, in fact, most of us, if we're on stroke medication, will be taking it in this morning window here, which is about the most dangerous time. Really, we need to get it in into the body earlier. In fact, some interesting new studies have shown that stroke medication taken before you go to sleep is more effective than stroke medication taken first thing in the morning in preventing strokes. The other, I suppose, important thing is how to prepare our healthcare services to deal with these peaks in pathology. In this case, are the ambulance crews and the hospitals sufficiently prepared for that sharp rise in stroke during the first part of the morning and the beginning of the afternoon? That's one example. Let's look at another example. And this is the impact of whole brain radiotherapy on overall survival in patients with multiple brain metastases, multiple brain tumors. And it was a randomized control trial. And the three treatments were radiotherapy between 8 a.m. and 11 a.m., radiotherapy between 11 a.m. and 2 p.m., and then the third group, 2 p.m. to 5 p.m. And these are the rather striking data. The 8 a.m. to 11 a.m. group, essentially everybody had died just after 6 months. The 11 a.m. to 2 p.m. All had died at 24 months. But as you see, there's a separation of the two curves. And the 2 p.m. to 5 p.m., 10% were still alive at 36 months. And this, I think, really emphasizes that same treatment, different time of day, interacting with our dynamic physiology can have a big impact upon, in this case, overall survival. Last example is rather topical, which is the time of immunization for the influenza vaccine H1N1. And this is in individuals over 70 years of age. And this was published, 4 years ago now in Vaccine. Two groups either had the vaccination in the morning, 9 a.m. to 11 a.m., or in the afternoon, 3 o'clock in the afternoon to 5 o'clock in the afternoon. And we see here the effectiveness of that vaccination in terms of antibody titer. Well, let's look at the afternoon group. And we see that the afternoon vaccination produced an antibody titer of about 100, whereas the morning group produced an antibody titer of 400. So 3 times greater effect having the vaccination in the morning versus the afternoon. And the point I'm trying to make with all of this is that so we can think of sleep, of course, but also sleep is part of a dynamic biology. And in fact, the point I'm trying to make is that time of day very much matters. And we must take that into consideration across the health spectrum. Okay, so let's now get back to sleep and this diagram that we saw earlier. And I really want to ask, well, what does sleep actually provide us? I know I'm talking to a converted audience, but I think for so long people have regarded sleep as this indulgence, this downtime where nothing much happens, and it's sort of a dispensable part of our biology. And I think the next few slides, if you needed convincing, will show you very clearly that sleep is actually a critical part of our biology and something we simply must take seriously. So what are the things going on? Well, very briefly, of course, there's the rebuilding of energy reserves and the sort of compartmentalization of metabolic status. So rebuilding of energy reserves and rebuilding metabolic pathways is a critical element of what's going on whilst we sleep, which is being regulated by the brain. The removal of toxic or harmful products is a very interesting area. And some of you may have been following the literature on the removal of beta amyloid, this misfolded protein that builds up within the brain and has been associated with Alzheimer's and dementia. Some very interesting studies, particularly from the Netherlands, have shown that whilst we sleep, originally the studies were in mice, now in humans, have shown that whilst we sleep, we're actually packaging up and getting rid of beta amyloid, lowering levels in the cerebral spinal fluid and reducing deposition within the brain. So one very interesting area, I think, is the removal of things like beta amyloid. There's also some data to suggest that sleep disruption and lack of sleep during the early years may predispose you to dementia and Alzheimer's. Now, I think that's a correlation, and we need to demonstrate cause and effect. But I think it's a very interesting observation that needs to be unpackaged. And of course, what's going on whilst we sleep? Coordination of growth and repair. I mentioned that sharp rise in growth hormone during the first half of the night. It's circadian driven, but what's very interesting is if you don't sleep, that release of growth hormone is hugely diminished. So the capacity to rebuild cellular pathways and to repair tissue is impeded if you don't get enough sleep. Let's look at some examples of cognitive function. And I think these are really some of the most exciting data to emerge over the past 10, 15 years or so. The laying down of memories, emotional and cognitive processing, and problem solving. And I think this is such an important area that I'd show you just a couple of examples of what's going on whilst we sleep in these domains. Let's look at problem solving. And one of my favorite studies, and this was from Jan Born's group, published now, 2004. And it was one of those breakthrough papers that began to, I think, change the way that people started to think about sleep and problem solving. So what Jan's group did was devise a problem-solving task. And what you see here is the percentage of the groups solving that problem. The first group, as illustrated here, were introduced to the task in the morning, and then they were asked to actually perform the task in the afternoon. So they had time, as it were, to think about what was going to be asked of them, the nature of the problem. 20% solved the problem. In the next group here, they were introduced to the task in the morning, but performed it the following afternoon, but they were kept up all night. They were deprived of sleep, and about 20% solved the problem. This is the interesting group, of course. Introduced the task in the morning, they performed it the following afternoon, but they were allowed to sleep normally, and you see that 60 to 70% of the group actually solve the problem. And I think this illustrates so beautifully that sleep promotes the ability to come up with novel solutions to complex problems. And I think, so much of the developed nations are dependent upon their ability to solve problems, that we must start to take sleep much more seriously. I just want to show another example here, which is sleep memory and emotion. I think this is very important. This is from Sickol's group, and he looked at two groups, those that slept normally and those that had been deprived of sleep for one night and hadn't slept for 36 hours. And the task was very straightforward. They had to remember words with a different emotional content. So positive words, happiness, joy, love, negative words, war, crime, hate, Trump perhaps might be one might introduce these days, and neutral words, things like cotton. Let's look at the ability to remember words, all of the words, in the normal and the sleep-deprived group. And you see quite clearly, and this illustrates very nicely, that if you're sleep-deprived, overall, you're less likely to remember words, which, of course, is well established. But now let's try and divide that up into the emotional content of those words. Neutral words, there was a trend to remember fewer words, but it wasn't significant. Very interestingly, there was a trend to remember fewer negative words, hate, crime, war, but it wasn't significant. What was incredibly significant was the failure to remember positive words, joy, love, and all the rest of it. And so what seems to be happening is that the tired brain has a different salience. It retains information about some things rather than others. And you see now an illustration that the tired brain remembers the negative, but forgets the positive. And of course, we'll touch on mental health fairly shortly. So the tired brain remembers the negative stuff in our lives. Okay, so this is the end of the first bit of the talk, really, which is the quality of our sleep defines the quality of our wake. And the two are inextricably linked, and you can't have a decent sleep without decent wake, and you must bear that in mind. Let's now look at some of the issues. And let's summarize the impact of poor sleep. Well, there are short-term consequences, of course, and there are longer-term consequences. And so the short-term consequences would be the sort of thing that many of us experience. Longer-term would be the sort of thing the business community experiences, or indeed night shift work. And the third group, which is those with mental illness vulnerability, there's an exacerbation of symptoms. And of course, the short-term, the long-term, and the mental illness are all inextricably linked. And this is a new figure. And when I was doing it, and I suppose maybe Christmas was on my mind, I thought, my goodness, look, it looks like one of those lovely Christmas angels. I think in this context, it's more like the avenging angel of sleep loss. And let's sort of look at some of these impacts in a little bit more detail. The sort of thing that you get with relatively short-term sleep loss, and that can be 1 or 2 days. Microsleeps, falling asleep at the wheel, 100,000 crashes on the American freeway system have been associated with falling asleep at the wheel. Loss of empathy, the failure to pick up those social signals from friends, families, and colleagues. Increased levels of frustration at relatively moderate things that wouldn't normally frustrate us. Increased irritability, reduced creativity, we've touched on that. Poor attention, poor motivation, memory impairment, which we've touched on. We've also touched on this negative focus, and impulsivity, the failure to sort of appreciate the consequences of actions. I'm going to make that red traffic light. No, you're not, but you go through anyway because you think you can. Longer term, I think, is really interesting, and this is stuff that you can see in the paper that I circulated. The impact of long-term sleep disruption on physiological and psychosocial stress responses, hugely elevated. I mean, it's quite extraordinary. And in fact, it's those changes that may underpin many of the other things that we see. So immune suppression. The one thing we know about high levels of cortisol, one of the stress hormones, is that it can suppress the immune response, which in turn could be related to higher levels of infection and indeed increased levels of cancer in long-term sleep disruption. Again, sustained activation of the stress response could be associated with cardiovascular disease, of course, higher blood pressure, increased stimulant and sedative use. So you're driving the waking day with stimulants and then trying to reverse that at night with sedatives. And of course, sedatives do not provide a biological mimic for sleep. They are sedating, as the name suggests, and in fact will harm some of the important things going on within the brain whilst we sleep. So, for example, memory consolidation. Metabolic abnormalities, and of course diabetes 2 and obesity are absolutely endemic of long-term sleep disruption. again related to probably the physiological impact of sustained activation of the stress response. What we're also appreciating is that if you're vulnerable to mental illness, there's an immense exacerbation of symptoms. So mood instability, depression, anxiety, again, substance abuse increased, hallucinations, paranoia, mania, and feelings of rejection are all hugely increased with levels of sleep disruption. And I just want to talk about one very important connection within the domain of mental illness vulnerability and the extraordinary association between sleep disruption and mental illness. This has been reported, talked about, since the 1880s. Kraepelin, the father of psychiatry, noted in mental illness there was sleep disruption. But it's largely been ignored until fairly recently. And in fact, a lot of the sleep disruption that you see in conditions like schizophrenia has been simply dismissed on the basis of either a lack of work. People don't have a job, so they're going to bed late, getting up late, or as a side effect of the drugs they may be on. They may be an impact of the drugs, but it isn't the causative agent, as I'd like to illustrate in the next slide. So how can we think of this extraordinary association between sleep disruption and mental illness? And the point I think I made earlier, or I hope I made earlier, is the immense complexity of the generation of the states of consciousness and wake. It involves multiple brain structures, and of course they regulate in a way every type of brain neurotransmitter system. Now, mental illness is underpinned by a change in a particular neurotransmitter system. So if there is a sort of common and overlapping neurotransmitter systems within the brain, then one would expect, or common and overlapping neurotransmitter systems that are shared by mental illness and sleep disruption, then a change in any particular neurotransmitter that predisposes you to mental illness will also at some level have an impact upon the biology of sleep. And so there is that association. So one would expect, for example, that genes that give rise to mental illness will also have an impact upon sleep at some level. And sleep generation will also, the genes involved in sleep generation and regulation will also impact upon mental illness. And we now have really very good evidence for that. So we've taken, for example, a gene linked to human schizophrenia, we've mutated that gene in a mouse, and we get interesting sort of behaviors, which I guess you can't have a mouse equivalent of schizophrenia, but you have behaviors that could be similar in some regard. But what's also fascinating is that those genes that have been linked to human schizophrenia, when disrupted in a mouse, cause changes in behavior, but also marked changes in sleep. So we're now getting evidence for that overlap, and there's really quite a bit of data for that. However, so there's that common sort of genetic predisposition to have mental illness and sleep disruption. But of course, it's made worse because sleep disruption, by its immense distorting effect, its short-term effects, its consequences in emotional and cognitive and physiological health, will exacerbate the conditions of the mental health state. And the mental illness state, of course, will then feed back to exacerbate sleep disruption. And that's again psychosocial and physiological stress, but also perhaps moderately influenced by some of the medications. And I think this is a really interesting way of thinking about the relationships. And by studying the two areas in common, we're learning a lot more about the physiological basis of mental illness and sleep. We can think, incidentally, of sleep disruption as often being an early warning of mental illness. So, for example, we have data showing that in bipolar, kids at high risk of bipolar, before there's any bipolar diagnosis, are already showing some elements of sleep disruption. But the bit I want to show you next is that we can think of sleep disruption as potentially sleep as a new therapeutic target in mental illness. And this is beginning to get quite a bit of traction in psychiatry and some lovely studies coming out of Oxford. I've been very lucky to work with the psychiatry department in Oxford. And excuse me, using that basic concept that I've just illustrated, this set of experiments arose, led by Dan Freeman. And this was individuals who were experiencing poor sleep accompanied by paranoia and indeed hallucinatory experiences. So this is the control group, which had no intervention. This is the level of paranoia at the beginning of the study, and the combined level 10 and 22 weeks after the study. This is the experimental group where sleep was partially corrected. This is the level of paranoia before the start. So again, no difference between the control group, but after 10 and 22 weeks, you see a very marked drop in the levels of paranoia, which were highly significant. So by just partially regulating sleep, improving sleep, you've actually reduced the severity of paranoia and hallucinatory experiences in these individuals. So I think this is a particularly exciting area going forward. So how much sleep do I need? This is the question that so many people ask. And one size absolutely does not fit all. You'll hear people saying you must get 8 hours. Well, I think that's wrong. I think the key thing is you assess your sleep needs, and then you try and make your environment as sleep friendly as possible. How do you know if you're not getting enough sleep? Well, it's fairly straightforward. If you're dependent upon an alarm clock or another person to wake you up, and you're not waking naturally from sleep, you're not getting enough sleep. If you oversleep extensively on free days and also holidays, some people are so revved up during the week that even if they can sleep in longer on a Saturday or a Sunday, they may not. But what tends to happen is that you unmask your more biological sleep pattern when you've had a few days off work and you're in the second or third day of a holiday. You take a long time to wake up. You show sleep inertia. You're feeling groggy and not alert, and it takes a long time to wake up. You feel sleepy, irritable, and fatigued when you're awake. You don't feel able to deal with the demands being placed upon you. You crave a nap during the day. Your behavior is overly impulsive. We've talked about that before. You crave caffeinated and sugar-rich drinks. The day is being fueled by caffeine. Altered behaviors, irritable, loss of empathy, disinhibited. Listen to your family, friends, and colleagues at work if they notice this change in behavior. It is these are the signs that you're not getting enough sleep. And this is underpinned by some very important, again, bits of our biology. The biological need for sleep or sleep duration is very variable, not only as we age, but between individuals. And I really wanted to make this point with this slide here. And what we see is essentially the broad areas of the range of sleep, the normal average range of sleep, but the again sort of the range in which can occur as we grow older and older and older. If we just look here for young adults and adults, we see that on average people are getting 7 to 9. That's why you often see about 8 hours. But some people can manage perfectly well on 6, and some people need 10 or 11. Now, they're rare, but they exist. And this is the point I'm trying to make, that you need to assess your own sleep needs. But also you need to distinguish between sleep and tiredness and fatigue. Sleepiness is cured by sleep. Fatigue, which is lethargy and an overwhelming desire to sleep, but not being vanquished by sleep, the fact that you can't do anything, there's huge inertia. That's suggesting that there's something else going on, and it may be indicative of another sort of pathology, and that's where you need to sleep help. So also distinguish between sleepiness and fatigue. But the key point is here that there's a huge range between individuals. The other thing that can be very different is your chronotype. Now, your chronotype, which is your morningness, eveningness, or being a neutral person in the middle, and I'll show some data on that, is certainly influenced greatly by one's genetics. You can have changes in some of the key clock genes, for example, which can speed up or slow down the clock and make you more of a morning or evening person. Your age can have a big impact upon your morningness and eveningness, but also your light exposure. We did a study fairly recently looking at university students, and we know that morning light advances the clock, makes you get up earlier, giving you an earlier chronotype, whilst evening light delays the clock, makes you get up later, giving you a more owl-like chronotype. And what we found in student populations across the world, done in Australia, Germany, Oxford, the Netherlands, was that the greater the evening light exposure, delaying the clock, making you get up later, the later the chronotype. So you have to be very careful to get a balanced morning light exposure and evening light exposure if you want to stay basically on track. So here we see an example of a population. This is data gathered by Till Roneberg and colleagues, showing on this axis larks, extreme morning types and extreme evening types, and of course a classic sort of distribution. The statistics vary, depends on the age of the population and who's done the study, and also how you define morning and evening types. But on average, it's about 15% of individuals are thought to be, quite early chronotypes. Most of us somewhere in the middle, about 60% of the population, and late types about 20% of the population. Why this is important, of course, is that it's given rise to the concept of social jet lag, which is invented by Till Roneberg. And essentially what this means is the social jet lag is the difference between you when you want to get out of bed biologically, because your sleep-wake systems have woken you up naturally, versus when you're being driven out of bed by the alarm clock. That's the social jet lag. And Till and others have shown the greater the social jet lag, the greater the mismatch between biological time and social time, the greater your chances of smoking, obesity, cognitive impairment, and all the other problems that we've talked about. So these are the two things that are contributing profoundly to our sleep timing and our sleep generation. Okay, let's now touch very briefly on solutions and wind up this presentation. Some of the solutions are included in a very short introduction. It was not meant to be a self-help book, but certainly there's some sections in there. But the paper I circulated comes from this Interface Focus. And Interface Focus is a publication by the Royal Society, and each edition has a completely distinctive theme. And we organized, Sally Shuttleworth and I, a theme on sleep and stress, past and present. Sally, for example, is was head of the English department in Oxford, and she's got this wonderful paper here, which is Overwork and Sleepiness in Victorian professional life. It's a wonderful paper, and it was mixed up with sort of biological studies, and I sort of recycled some papers into this particular Sleep, Circadian Rhythms and Health paper, which you have a copy of, I trust. And really why I'm flagging it up is because at the end of the paper are some sort of recommendations about how to get better sleep. And I won't go through these, but there are tips you can do during the day, before bed, the bedroom itself, and what you should be doing in bed, some do's and don'ts. And again, this is ways in which you can empower yourself and essentially, as I say here, above all, define what works best for you and stick to your routine. And it finishes with, I think, some important discussion about what an employer can do to some of the problems their employees may face. So, for example, one of the things that I think is really important is poor physical and mental health associated with sleep-wake disruption, whether you're a night shift worker or a stressed businessman, or indeed an NHS frontline worker. And so these individuals, because of the increased vulnerability, should have higher frequency health checks to detect problems early and institute corrections to prevent chronic conditions developing. And another area, again, high rates of obesity, diabetes 2, metabolic abnormalities. I worked in the John Radcliffe Hospital for 5 years, and it always struck me as extraordinary because the canteens were full of high-fat, high-sugar food, and there was no provision for small, protein-rich, easy-to-digest snacks that would keep people going. So I think there's some low-hanging fruit here that employers could institute also to improve the health and well-being of their workforce. And I think this is going to be an increasingly important issue. And indeed, I think that as an employer, one needs to sort of take on a duty of care and take these issues seriously. Okay, well, thanks very much. I hope you enjoy Sleep, a very short introduction.
That was tremendous, Russell. Thank you so much for that. I mean, it did overrun slightly, but I thought, the quality of the presentation, I'm sure we'll all agree, well worth it. We'd just like to share a quick slide of our next event, The Great Indoors by Emily Antis. And she's written this very, very interesting book about how we can sort of optimize our indoor spaces and a bit festive themed sort of Christmassy type of book club. So we hope that you can join for that one.